Good afternoon and welcome to our Wednesday webinar series. We're very excited for today's February webinar. It's all about coding and risk that you may face. Again, we have our special guest, Nancy Enos from MGMA Consulting, who will be reviewing the ways your coding will be costing you. This is from everything about establishing physician coding benchmarks to avoiding fraud and abuse in your physician compensation plans. My name is Brent Harrod. I'm a territory manager over here at Triarch Health. I'm very excited to have Nancy with us today, and with that, I'll pass it over to Nancy.
Great. Thank you very much, Brent, and thank you to all of you who have taken the time out of your workday to join us for this Learning at Lunch opportunity. Our objectives today for practices who are part of a hospital network, which is more common these days than it was a decade ago. How do the administrators of the physician practices, usually who are your legacy employees who are now working under a hospital administration, how can they work together to make sure that they have a culture of compliance for the physician practice, which is a little bit different than the compliance program historically for the hospital system overall? And how can you outline the importance of individual physician coding benchmarking? Because one doctor's numbers stacked up against everybody else's makes it a little hard to detect a problem and take action to prevent it from snowballing into a big financial mistake. And how can you analyze your financial compensation plans for the physicians? Are they getting paid on what they bring in charges? And will that be a risk in terms of coding fraud potentially or abuse? So the relationship between the hospital and the physician practice can often lead to coding risks falling through the cracks because of the numbers of smaller practices getting absorbed. And the other thing that I've noticed, I do a lot of auditing for hospital-owned physician practices. And depending on where the services are rendered, there seems to be a lot of variable because of operational issues. There's different staff in different clinics, different staff in the office, different staff in the hospital, and they don't do everything the same way. This can cause problems in charge capture and completing forms that everyone thinks the documents are complete, but when you look back and pull it all together, the doctor thought the nurse did something and vice versa. The whole hospital system can really suffer penalties if there's a compliance investigation and the paperwork was not really filed. And I don't just mean hospital clinics, I mean clinicians who go to nursing homes and rehab facilities and so forth. So I'm finding in my own audits that the site of service and the location can lead to some variabilities in good documentation. And auditing and monitoring and giving education to providers is also a real challenge for hospital systems because it's not something that they've done for a long time. In the physician practice, auditing and monitoring is the first element of the OIG's list of what it takes to have an effective compliance program. Can it detect and prevent fraud? Does your office compliance plan have an audit protocol that will expose all the hidden risks and not just look at the most common things without looking beyond that? So the most common things are services that are commonly provided, high volume for each division, for each specialty, and this is what you know are you most vulnerable because they're done all the time. You do a lot of level 4 new patient visits. You do a lot of level 3 hospital admissions. So you do want to benchmark to see if you're higher or lower than your peers nationally. Will the payers pick you up as an outlier, and are you ripe to be subject to an audit? That's why you benchmark, to see if you're an outlier, to see if you're raising any red flags. So rather than just look at benchmarking your group numbers, look at the individual providers, and if you have a low coding provider and a high coding provider, looking at the group will make them look normal, but either one of those is actually a problem. Compare the individual provider data to outside data, not just your group, but using national standards from the AAPC, from MGMA, from CMS, and then use that data to provide education to providers. Sometimes it's very valuable for them to see how they compare to the statistics because physicians are highly intelligent and trained and scientists, so they like data and they respond very well to benchmarking. This snapshot just gives you a picture of what the MGMA Evaluation Management Utilization Tool shows. It takes CMS data, by specialty. So this one happens to be internal medicine, and there's two graphs. The one on the left is the new patient outpatient visit, and the one on the right is the established patient office visit ranges. And the CPT codes, we can just put in the actual number that is reported in a month period, half a year, whatever period you want to for the provider, and then it will compare that against Medicare, and you can see the point differences. So you can see the red bars on the left is the normal bell curve for Medicare, and in this sample data we have it all in the middle. And on the right we have the same with the 99211 to 99215. You can pop in the actual numbers, and then the software will just convert that over to a percentage, comparing that to Medicare's distribution, and then the graph will show you what the difference is in the distribution. It's not meant for physicians to try and adjust their coding to mirror the national averages. They shouldn't have, if they think that all the patients that they see and the notes that they wrote reflect 99213, they shouldn't randomly take a couple and move them to 99212 or 99214 in order to achieve a bell curve that is representative of this graph. But it also should be based on medical necessity and what the actual documentation showed. But this does give you a starting point to see what should be audited, because you're looking at your high utilization codes. But don't leave it there, because sometimes beyond the office and the hospital notes, you have codes that aren't on the radar screen at all because your doctors don't use them. For example, I was doing a hospitalist audit and I saw a regular 99291 for the first unit of time for critical care, but then realized over a number of charts with excessive time that someone was failing to connect the 99292. The doctors were just writing down the time and thought the coder would add that, and the coder was only putting in what the doctors had indicated with the 99291 code. So there was a big opportunity there for lost money because there was a disconnect with who felt it was their responsibility to take that step. Another one is 99238 or 99239 for a hospital discharge day management of less than or more than 30 minutes. By default, it's 99238 if the doctors don't write down the amount of time. In some environments, the doctors might be writing time in their progress note, but not dictating in their dictation summary, things like that. Where is the time actually documented? Do the doctors know they have to document it, and what counts towards that time? And who is responsible for looking at that time and then converting it to the 99239 when the time does exceed 30 minutes? So not documenting time leads to fraud and compliance risks. Not looking at the time leads to missed opportunity for higher revenue. So it's really important for the practice to look at these codes that might never be reported, not just your high utilization codes, but also say to yourself, what codes are missing here? What else can we be reporting? Is there prolonged services codes? Is there screening codes? Are there new Medicare G codes? Is there something beyond this, normal range of codes that we should be checking into as well? The documentation variables I mentioned earlier really comes from doctors seeing the patients in multiple locations, and each location has a different method of the doctor documenting. There could be different EMRs at different facilities. There could be different forms and templates, and there could be, of course, different staff members who have different responsibilities in terms of nursing notes and intake and writing vital signs and taking patient histories. So all of these things make 10 charts for similar visits by the same physician look totally different depending on where that was rendered. Is it a nursing home? Is it a bedside procedure? Is there a procedure note written down? Wound care centers can be variable as well. And home visits, satellite offices that don't have access to the main electronic health record, all of these things can cause the secondary sites to have documentation that is poor. If your audit only focuses on documentation of a sample of notes from your primary office, you might have a great result and not realize that the other 20% of your off-site services are a problem. Extra services are also sometimes either not documented and billed. Sometimes I read an OB/GYN note and it says in the physical exam a pap smear was done, but there's no actual procedure note. Or in the assessment and plan that a debridement was done, but there's no procedure note for that debridement within the visit. If a CPT code is assigned, adequate documentation to separately support that billable service, whether it's a diagnostic service or a therapeutic service, has to be in the note. And we're used to seeing injections mentioned during, documentation of an office note in the SOAP note, and that's fine, but it has to say what the route of administration was, what drug was given, how much, what the reason was, and not just something that's, checked off on the billing slip at the end of the visit. Everything that has to be an extra service, what I mean by that is things that are beyond the basic evaluation and management service that is being billed. Routine services also can be a problem in terms of should they be billed. Hospitals have requirements for quality as far as pre-op and screening and clearances. Hospitals require the physicians to dictate a history and physical prior to admission for surgery. But if it's included in the global for the surgeon, if it's done the day before or the day of surgery, how is it medically necessary if that is done 2 days before the surgery? Now, once the surgery is scheduled, use caution when billing for routine services, especially if the chief complaint for the visit starts out by saying, here for pre-op, and nothing is discussed, nothing is assessed, and nothing is decided. Those are really not billable visits if they're routinely done before surgery. When the surgeon refers a patient to their PCP because the patient has specific medical conditions such as diabetes, high blood pressure, or heart disease, then Medicare will cover the consultation by that PCP or cardiologist if it's medically necessary. But the HPI for that physician who's doing the clearance should indicate what the medical issues are that require the clearance, documented in the review systems, the physical exam, and the medical decision-making. Then that pre-op consult is sent back to the surgeon, telling them that they allow the patient to go through surgery. So that's really where Medicare does say that they will pay for a pre-op consult, but that's a lot different than routine H&P by the surgeon. Office procedures also can be underdocumented. When there's an office visit and you have a history, exam, and medical decision-making, and then the assessment plan says the wound was debrided, that's not enough. For example, wound care codes have specific criteria on the size of the area that's debrided, the depth of the debridement, whether it's a surgical debridement or a wound debridement. So the physician who's performing that debridement has to document the area of the wound, the depth of the wound, the size of the wound. A procedure note should be completed just like a mini op note. There should be an indication for the procedure, the method, what scalpel and things like that were used, high pressure water, any supplies and medications that were used, and the condition of the patient at the end of the procedure and instructions to the patient. That makes it look like a clearly documented, separately billable service, other than a 99213 with a modifier 25 and then a little note that says debridement done. You need a lot more than that to support an office procedure. And there's a lot of reviews that pop up as a result of using modifier 25 on a routine basis. So this is just an example of what a debridement looks like. According to the CPT, the 11042 debridement is the depth is subcutaneous and the tissue measurement is 20 square centimeters, not linear centimeters, but 20 square centimeters. So the measurements need to be there. And then something about how the doctor surgically removes the foreign matter or the contaminated or devitalized tissue by the different methods, and usually this is caused by injuries, infections, and wounds. There are different wound debridement codes for burn wounds, so the cause of the burn is important to distinguish by the etiology. Or chronic ulcers also have different codes. So be very careful about how the description of the procedure is documented. Modifier 25 requires that the physician write a SOAP note, history, exam, assessment, and plan. If it's related to the procedure, it's usually bundled. The chief complaint and the HPI, if patient comes in for another debridement of the wound, then that would tell you right there that you should only be billing for the wound as is supported by your procedure note. If the patient comes in for assessment of a wound, and during that assessment, the doctor determines it's appropriate to do a debridement, and this would pertain to any kind of office procedure, whether it's removal of impacted cerumen in the ears or an injection in a sore shoulder. But if the visit results in the decision that it's necessary to do something for diagnostic or therapeutic reasons, then it would be separately billable with modifier 25. But if it's a planned procedure or a planned test, then it's not going to be billable. You can only bill for the procedure code for that procedure based on why it was done and the documentation in the op note or procedure note. Other places to look when you're doing an audit for your variables, including site of service and unusual services, is who's performing the service. Sometimes if you have non-physician practitioners, such as nurse practitioners, physician assistants, and residents who are assisting doctors in writing the notes, CMS has changed that ruling as of January 1st. It's not necessary for the attending physician to rewrite what the resident wrote down. But when I do notes, I find that a lot of the non-physician practitioners do write very thorough notes, but there's this myth that they should code a little bit lower because they're not the doctor. And the level of service is based on medical necessity, the extent of the service as documented in the exam, the assessment, and plan, and there's no rule that guides a non-physician practitioner to downcode their services. So a problem that's a 99213 for a physician or surgeon is the same 99213 as the non-physician. So it really just is by the guidelines, the level of service, and good documentation. Also, non-physician providers do a lot of teaching, and they can document time and bill according to the time spent as long as it was medically necessary. The teaching physician attestations have changed, as I mentioned, so the teaching physician has to document personally that they performed the service or were present during the service and that they agree with the key portions provided by the resident. I have a love or hate relationship with electronic medical records. So this slide really talks about how suspicious I am when I audit notes and I realize after the 20th note that I'm reading the same thing over and over again. And a few years ago, I did a study with the OIG. It was part of the work plan, and they did a study on authenticity of notes because they were seeing a lot of upcoding as a result of cloned notes and copy and pasted notes. And if something is copy and pasted because it's necessary for it to be in this new note to avoid having to go back and get important information, that copied information should be dated and then followed by the new information that is dated. And I think a best practice is to make the new authentic information bolded or in a different font so you can refer back to the old, but then see what clearly is the new, and only give credit for the new information. When you're looking at the elements for HPI, that really is the story between what happened to the patient between the last time they were seen and this current visit. Clone notes means that the HPI has the same exact content, the review system has the same content, the past and social history has the same content, the physical exam has the same content, and it can't be true for every patient every time. And also it can't be medically necessary if the patients come in for different reasons for them to have the same exam for all the different patients that were seen in a given time frame. So what happens when there is clone notes and the automated text is there. You read something that the doctor wrote in a narrative, something that was unique and intentional. The patient is here for bruising. And then the review of systems is just click and auto-filled. That will conflict with the HPI because a lot of times the hematology and lymphatic system review says patient has no bruising. That really negates what the HPI says, that the patient is coming in today complaining of a bruise. The same thing can happen when there's no update to family history. Family history in the past could say the mother has malignant melanoma, or the family has no skin cancer, one or the other. The patient comes in a future visit and says they're here for a suspicious mole, and they're nervous because their mother had malignant melanoma. Well, if the family history isn't updated, then that's going to, again, create a conflict between the HPI and the family history. The extent of the physical exam is something that we see a lot when we audit records, and having a detailed exam or a comprehensive exam when the patient comes in for a self-limited or minor problem like a sprained finger, and there's no problems noted on the exam. You wonder if it was actually done at all. I asked the OIG when I was getting trained to do the project for them, how would they view this if there are extra elements or superfluous information in the physical exam, but the HPI and the history and the assessment and plan really do seem to be authentic in terms of why the patient was there, like a sprained finger. And the OIG said there could be extra elements because it's part of the physician's training to check the eyes, ear, nose, and throat, and belly. I'll use a pediatric practice for example. My dad was a pediatrician, and he always checked his patient's throat, no matter why they were there, and checked their belly. It was just his training. It was his standard of care. If the code selection is not higher based on the extra exam, it's not a problem. If the code selection is higher based on extra history with that complete review of systems and extra physical exam with a comprehensive exam beyond the medical necessity, then the code might be too high if it's not supported by medical decision-making. So be careful that medical decision-making is always going to be your part of the elements in choosing the level of service. And don't go to a higher code just because you have a detailed history and a detailed exam. It won't be a 99214 if the medical decision-making is straightforward. Drop that down to a lower code as appropriate based on medical necessity. The ICD10 detail also depends on the information in the note. So we know that the billers and coders are trained not to use the unspecified codes and should go back to the provider, not change the code by looking up a better code themselves. I know that coders are very good at searching for the best code, but the note has to support it, and the note can only be changed by the doctor. The same thing with modifiers. Any modifier means that certain circumstances were present in the note, not just that a biller knows that a certain insurance company requires a modifier to get the claim paid. It also has to start with the note supporting medical necessity and a complete description of the services. So what do auditors look for if you are sent a note and a letter and asked to send notes to a payer? You need to be aware that they're going to look for charges that are outside the normal bell curve, services with specific requirements like new patient office visits, inpatient admissions, observations. All of these have to have a comprehensive history and a comprehensive exam. So that means 10 points review of systems, past, family, and social history, and an 8-organ system comprehensive exam. So all of the service ranges on this list are most of the times the ones that I see a high error rate. Also, auditors will look for unusual billing patterns, billing for things that are commonly bundled, unusual frequency or unusual volume of service. Once the auditor looks at the note, the most important thing is to make sure that every note is complete because they have to stand apart from others. So if something is listed in a previous date of service, you can't assume that that information is going to be looked at by an auditor who's auditing one specific claim and the documentation to support that. So it has to be a chief complaint is why the patient here today. So you can't say something vague like patient here for recheck, even though you can look at a previous note, an auditor can't and won't look at a previous note. If the patient's being seen for follow-up for tests, again, the reason for those tests should be there as well. Without a valid chief complaint, some auditors will deny the claim without even reading the rest of the note. That's because it doesn't support medical necessity for coverage. So follow-up, 6-month follow-up, routine visit, even worse, here to establish care. I've actually seen the verbiage, here for meet and greet, or patient isn't sure why they're here. So you can't argue with that at all. Sometimes the HPI will indicate the service is a different category. Patient was seen 2 years ago for a lesion, and they're billing for a new patient, or John's here to establish care. He's new to the area, has no complaints, and they billed a 99204. Well, has no complaints means that it's a routine preventative exam. So that in black and white is telling us that it should have been billed as a preventative code. Sometimes they're trying to bill the new patient visit and then do the physical at a separate date, or maybe the patient had their physical within the previous 12 months and doesn't have coverage for it yet. But if that's the case, they'll have to wait and schedule the appointment for when they do have that. Or document that they're here to assess their chronic illnesses or problems if they do have anything that requires medical attention. The HPI is the starting block for the level of service. It really has to be scored to support medical decision-making. You want to make sure that if you're doing the 95 guidelines, they work best for acute, spontaneous new problems or sick visits, as we say. And the 97 guidelines will allow you to document the status of 3 chronic conditions. And you can use either set of guidelines, whichever works best for you, for any given visit. You don't have to stick to 1 year's guidelines or the others. So the 95 guidelines have brief with 1 to 3 elements or extended with 4 or more elements. And I always tell providers 4 elements is easy. How long has the problem been going on is duration. Where is it hurt is location. How would they characterize it as quality? How bad is it is severity? So you get the picture. 1 brief sentence can give you plenty of information. And then 97 guidelines is good for general medicine, internal medicine, where patients are coming in for follow-up of their heart disease, hypertension, diabetes, that sort of thing, where the HPI is just going to say what they're doing for each of those conditions and how they're doing with each of those conditions. So you might not have 4 elements there, but you still can document an extended HPI. The review of systems. Some don't document a separate review of systems. Some providers will say the last sentence in their HPI is going to be organically part of the review of systems, and that's fine. They can say patient denies nausea and vomiting, for example, and that's the GI review of systems, even though it's in the HPI paragraph. It doesn't have to be a complete. But for a new patient for 99204 or hospital admission, they do need to have a complete review of systems, and most carriers do allow for the positive and negatives that are pertinent to be individually documented, followed by a statement that says all other systems are negative. As long as that is true, that is sufficient documentation. But you want to avoid things that are unclear, such as unremarkable, no other complaints today, or non-contributory, because that doesn't actually indicate how much was asked. Some EMRs have templates that make it easy to document a comprehensive history every time, but there are a lot of pitfalls, and it really makes auditors suspicious because things will contradict. As we mentioned, the HPI, when a patient has a rash on the arm, and then ROS says no rash, or the ROS makes no sense for the patient's gender. It's a female patient, and the review of systems automatically defaults to no erectile dysfunction, or things about the patient's occupational living status that have changed but haven't been updated, or things about the patient's past medical history or their family member's medical history not being updated, causing conflicts in the statement as well. Family history has to be specific to family events that put this patient at risk. hereditary conditions, diseases, or age and cause of death. So phrases like non-contributory or a notation that the patient is deceased is not sufficient. And we do see family history non-contributory overused still today. The physical exam does have to have 8 different organ systems, and sometimes we'll see more than 8 different headers in the physical exam, but neck is not an organ system if you say neck negative, because we don't know if they're looking at range of motion for a musculoskeletal exam of the neck, or if they're looking at swollen glands for a lymphatic exam of the neck, or looking at stiffness for neurologic exam of the neck, or looking at jugular venous distension for cardiac exam of the neck. So neck negative, things like that really should be avoided. And if they use these combination acronyms like HEENT, which stands for head, eyes, ears, nose, and throat, you can't get credit for the eyes and the ENT with that one statement because it just says one word, negative. It's better to say eyes, pupils equal and reactive to light and accommodation, or mouth, normal oral mucosa is moist, and things like that. Be more specific as to what was found, what was observed, and then the auditor will know why it was observed as well to support medical necessity. There have been a lot of changes since the 95 and 97 exam guidelines came out, and in 2017, some Medicare contractors actually considered going instead of 2 to 5, 2 to 4, and 5 to 7 for expanded problem focus versus detailed, to 2 to 5 and 6 to 7. This was put back on hold because there was a lot of pushback, and I'm hearing now that they might even go the other way and be a little bit less stringent on counting the organ systems for the expanded problem focused and detailed exam. One of the things that some payers do is look to see how much is specified before allowing a detailed exam. So if you say 5 systems, but they were all just one word, negative or normal, that would not be considered a detailed exam. The most important of the 3 key components is medical decision making. The number of diagnoses that are listed in the assessment have to tie back to the reason for the visit and physical findings in the exam that are documented. They shouldn't be mentioned in the assessment plan for the first time in the note, or they shouldn't simply be copied from the patient's past problem list. The reason for laboratory or x-rays should always be spelled out during the encounter as well, because that bumps up the level of medical decision making, and treatment options such as medications that are prescribed, physical therapy or other therapies that are ordered, or surgery that is planned is also going to be part of the decision making in terms of what is the level of complexity. The assessment and plan part of the note is where the auditors look for a list of diagnoses that were treated or that were factored into the treatment. So it's important to list comorbidities that make a patient more risky than a patient who's otherwise healthy. That always adds to the level of complexity. And it's also important for the auditor to know whether a problem is new, stable, improved, or worsening, because that changes the complexity as well. One of the problems that we see a lot is just copying past problems that were not assessed in the current visit. So if a patient comes in for a sprained ankle and then all of a sudden lists all these things like ankle pain, a sprained ankle is painful, so that's not 2 separate diagnoses, or other things that are irrelevant, such as lactose intolerance, seasonal allergies, a history of migraines, psoriasis, and then billing as a level 5 visit because of the number of problems listed in the assessment. If they weren't all truly evaluated during that visit, they should not be listed. The amount of data also contributes to the complexity, whether the decision to order test is being made or the results are being reviewed during a visit. And those are going to be categorized by the type of test, laboratory, x-ray, tests in the medicine section like neurology and cardiology, respiratory tests, looking at records from another facility. If they summarize them, then they get credit for reviewing them. Saying that they read them without further mention doesn't really count. And personally reviewing some kind of a test, EKG reading is personally reviewed, or an X-ray is personally reviewed, is more descriptive and will give more points as well. And the table of risk will give the biggest factor in determining the overall risk based on the presenting problems or the management options or diagnostic studies that were done. So if a patient comes in with symptoms of a cold and is prescribed an antibiotic, even if the EMR helps create this comprehensive history and exam, if you looked in the CBT book, you know that 2 out of the 3 requirements for 99215 are satisfied, but a cold is a low-risk problem, and that would only support a 99213. So I can't emphasize enough that risk is really important in risk-based coding. The exception to the rule is time. If time is the overriding factor because greater than half of the visit was spent in counseling and coordination of care, the doctor can look at the 3 bullets on this slide and document the total length of the encounter from start to finish without counting the time it takes to do any separately billable procedures. A statement that greater than half the time was spent in counseling, and then summarize what was discussed. And if that's the case, then a 25-minute discussion can be a 99214, even though it's one previously established problem that took a long time to discuss and educate the patient. It's an easy way for providers to document in their note to support lengthy counters that were based on counseling. Sometimes no exam is documented when the patient comes back with family members to discuss test results, for example. And auditors will skim to the bottom and see if time is well documented, if they're finding at the top of the note that the key components were not supported by the visit. The ICD10 codes are also very important. They have really mandated that a lot more improved data by specified conditions are documented, right and left, acute and chronic, things like that. So that will also have a good improvement in terms of clinical documentation because of quality measure reporting and other ways of reimbursement like HCC coding that we talked about in our last webinar. So clinical documentation is really important. I won't spend too much time on these slides because it reviews a little bit of what we talked about last time, but it is important because it is a legal record as well as a billing record, and it will get your claims paid faster if you have all the information that you need on the first pass. So besides getting you out of risk with compliance, it also does have a positive impact on coding and billing and your reimbursement. And the ICD10 codes will improve the notes, and those notes will then also support your CPT and your modifiers so that you have less errors in charge entry, and you'll receive your payments in a timely manner with less denials. So when you're in a physician practice that is in a hospital network now, if your hospital administration is working with the practice and has physician compensation that is based on RVUs, are there incentives to bill things that you didn't normally bill in a private practice, so that might not be paid by payers, like the first OB or first prenatal visit when the patient comes in and it's already been confirmed that they're pregnant, or the patients who have post-op visits? Are you now putting them in to track productivity for the physician? Do you have a mechanism to put them in with a 0 RVU or a 0 fee so that you don't get into problem with billing, but you are still reporting your physician productivity to the hospital? I think a lot of these hospital relationships have really changed the way physicians are sensitive to their tracking of utilization for their RVUs, but you want to make sure that they don't do it in a way that's going to lead them down the road of billing fraud. And the way to do that is to look and see, have you had an internal chart audit by someone who is a qualified auditor? We're not perfect as humans, and sometimes it's not common for us to find our own mistakes because we'd like to think that we're doing things right in the first place. So getting an external auditor, getting a fresh pair of eyes to confirm that we're doing the right thing is always the safest way to go. When you do an audit, don't just look at your primary place of service. As I mentioned in the beginning, your office notes usually come out pretty good in an audit. But if you start to look at those ancillary or secondary service locations where you might have practices for documentation and coding and billing that are not as good as they are in your office, that's where you really want to find out, if you can tighten up things and avoid any errors. And are you focusing on all types of service and not just your core types of service? But make sure that you're looking at all those things that make up less of your service list, but those can be the problems as well, things that you don't do all the time. You might not be documenting them right, and you might not be coding them right. So that's really important as well. So hopefully this checklist and this presentation has given you some food for thought in terms of, what do auditors look at? What do I need to look at in terms of benchmarking, in terms of documentation and code capture, and good documentation for your diagnosis codes as well. So at this point, I will see if any of the attendees on the call have any questions. And I know that this is recorded for others to listen to at a later date. And if you have any questions, my email is nenos@mgma.org. And you could certainly send me an email if you're listening to this other than live and have a question to follow up with me. I'd be glad to get back to you. Thank you.
Hey, Nancy, it's Brent with Triarch.
Hi.
I don't see any questions coming in, so I'm guessing you did an awesome job because I don't see any questions here right now, or people are just getting their brain wrapped around all the information you provided them. If people do have questions and Nancy can help out, I can get that information over to Nancy. At this point, I want to thank everybody for attending our webinar. Also thank Nancy Enos for all the wonderful information she's provided us with today. We are going to be putting a recording of this specific webinar on our webpage. Also, please visit our Facebook page to view our live drawing for an Amazon Echo speaker. Everyone that attended today's webinar has qualified for that drawing. So please go to our Facebook page where we'll be doing this live. Also, please go to our webpage or website to sign up for our next Wednesday webinar in March. And lastly, if you have any questions about any of the information, or if you'd like to get some more information about Triarch services, please contact our support team at incident@triarchhealth.com, or you can reach out to your territory manager, myself, Brent Harrod, or Patrick Murphy. Thank you again for everybody in attendance, and thank you again, Nancy. We really appreciate the job today.
My pleasure. Thank you.
Thank you.